Two, one. Please start.
Hello everyone. Hello everyone. Welcome you all to this webinar session on heart to heart live session on fetal cardiac anomalies. This session is organized by FOGSI Imaging Science Committee in association with Indian Society of Prenatal Diagnosis and Therapy. I, Sutopa Singha, genetic counselor, welcome you all on behalf of Lilac Insights, the academic partner of this webinar session. Moving forward, I would like you to introduce you to Dr. Bela Bhatt. I would like Dr. Bela Bhatt to speak few words and then we can start the ceremony and introduce Dr. Niharika later.
Thank you so much, Sutopa, for that kind words of introduction. Well, as a chairperson for the Imaging Science Committee and as a managing committee member of ISPAT, I extend a warm welcome to you all to this unique webinar of Heart to Heart about three-dimensional approach to cardiac anomalies. Well, as a part of activities of Imaging Science Committee, I have conducted various webinars as well as physical conferences, but this is a unique one. Why? Because we know that as soon as a cardiac anomaly is detected on anomaly scan, well, that's not an end of story. That's actually beginning of a story because that's when we would like to prognosticate and counsel the patient. And how can we do that without consultation of pediatric cardiac surgeon and clinical geneticist? Because we know both are very, very important to know the prognosis of that particular cardiac anomaly. And that's the reason we have included today Dr. Ashutosh Singh, who is a pediatric cardiac surgeon, and Dr. Eshan, who is clinical geneticist, as a part of our team. It's going to be a multidisciplinary approach. So welcome, Dr. Ashutosh and Dr. Eshan. Uh, well, I'm sure, yeah. I'm sure the team will keep you engaged till the end because we are going to have wonderful interactive session, unlike just the three talks. So I'm also very glad. I'm also very glad to have very dear friends from FOGSI, Dr. Sneha Bhuya, Dr. Tarini Tareja, and Dr. Varsha Lahare as the faculties today here who are going to chair this session. And I wish them all the best in the FOGSI, in their endeavors in FOGSI. So welcome, dear friends.
Thank you so much.
And of course, it's our honor and pleasure to have the President and Secretary of ISPAT, which is Indian Society of Prenatal Diagnosis and Therapy, Dr. Saurabh Dani, President, and Dr. Manjeet Mehta, Secretary, who are here with us today. So can we have blessings from them? Niharika, have you joined? Has Niharika joined? So welcome.
She is not joined, I guess.
So welcome, Dr. Saurabh Dani. We all know you, not just as president of ISPAT, because in this year you have done wonderful academic activities of ISPAT and you have taken ISPAT to a greater height, as we all can see. We know you as a past president of AFG, of course, because we have old connection and the most tech-savvy person in AFG and ISPAT that we have. Of course, he is coordinator of strategic leads and development, Everheal for comprehensive women and child care, and coordinator MCGM newborn screening program. He's also known as a newborn screening program person all over India. So without much ado, I will request Dr. Saurabh Dani to say a few words.
Yeah, thanks, Bela. And I know we all have been connected on various other platforms. And it's a wonderful idea to have a discussion, a rather intense discussion on such an important matter. Just to highlight a very important part is that we can't know, definitely that the incidence of congenital heart disease is incidence almost 1%. But looking at the size of the population India is, when you talk in actual terms, the amount becomes so huge. There are so many cases of critical congenital and congenital heart disease that we see. And I hope through the discussion, you will discuss all the matters that are at hand, which include when to decide to continue the pregnancy and when, which are the indications where you need to ask the parent to terminate the pregnancies. And these are going to be very important decision-making tools, because you need to understand that in India, we have limited resources for all this kind of serious problems. And before I hand over the space
ठीक है,
to
शुरू हो
my
गया, ठीक है.
secretary, I would just like to say, let us also think about the opportunity that screening of a newborn can also
अब
forward.
बोलते हुए कैसे
About
इंटरप्ट
screening
कर
of
दूंगा मेरा.
the
नहीं
newborn to
नहीं को
predict the
इंट्रोड्यूस
prenatal
कर.
heart rate. And that's something that we should consider going forward, because not every disorder is going to be detected in the prenatal period. We won't have the best of sonologists like Bela available everywhere to do all the hands-on training everywhere. Do we have a good handsome of good sonologists? But we are going to miss out. Things are being missed out across the world, and I'm sure they'll be missing out in India as well. So the earlier you detect the problem, the better outcome you can give. So with that, thank you, Bela, for inviting and including Ispat in this program. And I'm sure there are more activities that we can do together.
Thank you so much, Dr. Saurabdani, for those kind words of wisdom. Niharika, are you there to introduce Dr. Manjit Mehta?
Very good afternoon, and extremely sorry for this inconvenience. I had a ruptured ectopic, so I just dewashed. So, what a wonderful sunny day, and what a wonderful person that I have the privilege to introduce. The gorgeous and a very knowledgeable Dr. Manjeet Mehta. She's the dynamic secretary of ISPAT, and just like not less than the president, she is as lovely and as beautiful person to be with, to talk to. Madam, it is a privilege to have you both with us in this webinar. From heart to heart, we welcome you.
Thank you so much for these kind words, Niharika. You've gone overboard in praising me. And I'd like to congratulate Dr. Bela Bhatt on this amazing webinar that she has put together. I just love the choice of topic. And also on behalf of ISPAT, it is something really good that, people are getting into these fetal specialities. And we all know that genetics has entered mainstream medicine. This knowledge of human genetics has increased so dramatically, and the obstetricians, all the healthcare providers, they are increasingly incorporating genetic testing into medical practice. And now our advances of the molecular basis of various inherited diseases has led to the development of DNA-based tests for prenatal, postnatal, neonatal, carrier testing, and aneuploidy screening. So with these few words, I welcome you all, and also invite you to be ISPAT members. We are doing a lot of academic activities in the prenatal, perinatal space. Wishing all the best to the amazing faculty that we have today under the able leadership of Dr. Bela Bhatt. Good wishes, everybody.
Thank you so much, Dr. Manjit Mehta, for those kind words of encouragement. Niharika, can we?
Yes, we will continue in our this webinar with the blessing of every senior and guide. So I introduce with my privilege to introduce Dr. Sneha Bhuyar, who is our chairperson, one of the chairperson. Madam is a very well-known figure all around the country, and she is a recipient of many awards, including this very famous National Individual Award of the FOGSI. Madam is always there to help and always there to teach as much as she can. She is a very well-known laparoscopic and infertility specialist in Pune. And Sneha, madam, it is so nice to have you with us. I would like to introduce our second chairperson. Before that, I would like So, okay, fine. I'll introduce all of them. Dr. Varsha. Dr. Varsha is the president of NASIC Obstetrician and Gynecology, and Madam is also very active in AMOGS, being the zonal coordinator. She is the director of Prayag Hospital. Thank you, Madam, for being present. And our third and final faculty chairperson for this evening is Dr. Tarni Taneja. She's a very dynamic personality in the north of our India as well as all around the country. She is the chairperson of Delhi chapter ISPAT and the vice president of IMA. She is also the chairperson of ISAR and a very very active member to be the national ISAR executive member. She has been awarded many awards, and Madam is a very humble and a very gentle person to talk to, always there to help us and always there to guide us. Thank you, all the chairpersons. Please say a few words.
So a very good evening to all of you. Thank you, Dr. Niharika, for that wonderful introduction. And of course, thanks, Dr. Bela, for the invitation. Hearty congratulations to Dr. Bela. And of course, thank you, FOGSI President Dr. Jaideep Tank and Madam Madhuri Patel, and also the ISPAT President Dr. Saurabh Dani and Secretary Dr. Manjit Mehta for having us here. I would just say that Niharika, though my entire education is from Pune, I'm settled at a small district place that is Yavatmal. And I was the FOGSI Breast Committee Chairperson and Governing Council member of ICUG. And at present, I'm amongst Emergency Obstetrics Committee, and I'm working on all the aspects of high-risk obstetrics. Of course, I'm very privileged to be the member of ISPAT as well. And thank you so much for having me here. I think the other chairpersons can say a few words, and it will be my pleasure to listen to Dr. Bela Bhatt and Dr. Ashutosh Singh discussing about the topic of broken heart. Quite interesting.
I think Dr. Sneha and Dr. Tarini can introduce Dr. Bela, myself, and Dr. Ashutosh, because first session is little different. It's a combined session by me and Dr. Ashutosh.
Yes,
So
that is what. So can we have the CV of Dr. Bela Bhatt?
Yes.
So in fact, a very dear friend, Dr. Bela Bhatt, the chairperson of FOGSI Imaging Science Committee, and of course, a lead consultant in the Dr. Bela's Women's Hospital and Fetal Medicine Center, Andheri. Dr. Bela is a fetal medicine consultant at Dr. Babasaheb Ambedkar Memorial Central Railway Hospital as well, and she's a FMF UK certified sonologist for fetal abnormalities, also the FMF UK certified sonologist for knuckle scan. She's the author of various books and of course the recipient of certain few awards as well. So she's the author of Vital Skill Ultrasound in Obstetrics and Gynecology, and very good orator, I would say, having best of the knowledge of this imaging science. So we would like to listen to you, Dr. Bela.
One thing more about Dr. Bela, she is a really born artist. She's a very dynamic and dancer and beloved dancer of FOGSI and EdPAR India.
Thank you.
So I invite Dr. Bela for the presentation.
Can you also...
Can we have the second chairperson CV as well?
Yeah. So first of all, Dr. Niharika, thank you so much for kind introduction. You are really, really very pleasing and very lovable to all of us, and doing the fantastic work with Dr. Rajul Tyagi. We are proud of you, dear.
Thank you.
I have the privilege to introduce Dr. Ashutosh Singh. He's the MS MCH FIS. Yes. His specialization is congenital heart disease, surgical treatment, total correction in initial cardiac surgical pathologies, and neonatal open heart surgery, and adult congenital heart surgery. He is a gold medalist and so many awards to his credit, and has so many membership, Society of Pediatrics, World Society of Pediatric Surgeons, Asian Association, so many more like accolades to his credit. He's a very great speaker, a good orator. So over to Dr. Ashutosh Singh. I don't know first who will going to take on one by one, Dr. Bela and Dr. Ashutosh. So over to you, Dr. Ashutosh.
Thank you so much for those kind words of introduction. I'll just share my screen. Give me a couple of seconds. Okay. And screen. Hope my screen is visible.
Yes, very well visible, dear.
Okay.
You also very visible.
Okay, fine. So as I told you, this is going to be a different kind of uh, mm, talk. It is not just talk, but it will be a dialogue between me and Dr. Ashutosh Singh, who is a very senior, experienced pediatric cardiac surgeon. And we are going to discuss about antenatally detected cardiac anomalies. And so I have some 5 conditions that I have chosen, which are common cardiac anomalies, which are antenatally detected. And then on each we will discuss. And at the end of this discussion or the dialogue, then we'll have inputs by our clinical geneticist, that is Dr. Eshan. So we get a 3-dimensional approach about the cardiac anomalies, right? Now, why do we want to know about cardiac anomalies? Because as Dr. Saurabh also mentioned, we know that there is a high incidence of cardiac anomalies. 1 to 2% in the population, we find that there is either minor or a major cardiac anomalies. And why do you want to pick them up antenatally? And why can't you pick them up postnatally? Because antenatally, once you diagnose them, if it's a complex CHD or congenital heart disease with a poor prognosis, then we can offer the option of termination of pregnancy. But there are many conditions where there is good prognosis, availability of postnatal surgeries, where we would continue by monitoring and then delivery at a tertiary center. And it has been found based on studies that postnatal surgical outcomes are better in antenatal diagnosed cases. For obvious reasons, we select a tertiary center and the patient is ready, financially ready, mentally ready for surgery and treatment in the postnatal, and is treated delivered at the best center. And we know that many of these cardiac conditions have genetic association, and therefore we have a geneticist also. So it's always a multidisciplinary team which decides the prognosis. So once the anomaly is diagnosed, the first question that comes, either you are a fetal medicine consultant or an obstetrician receiving a report of cardiac anomaly, first thing is, how am I going to counsel this patient? So for that, we must know about the natural history of that condition, the cause of it, and what is the available treatment and postnatal outcome. And that is the reason why we have this team of myself and a pediatric cardiac surgeon, Dr. Ashutosh Singh, and a clinical geneticist, Dr. Ishan Debhade. We know we can't manage such patients without teamwork. And this team is going to really work hard today to help all of us out. So as far as fetal heart imaging is concerned, I'm not going to go into details of diagnosing fetal anomalies, but I'll just be presenting some salient features. So whenever we do an anomaly scan, the mid-trimester anomaly scan, 18 to 22 weeks, there is a basic screening of heart, extended basic, and then in some of the cases, we have to do detailed fetal cardiac echocardiography. Now, because of the advent of higher-end machines, the better skill and training in ultrasound, antenatal ultrasound of fetal heart, we can look at the heart closely. And when we look like this at the 4-chamber view, the 3-vessel view, the 3-vessel trachea view, then, and of course, we make a use of color Doppler where we can clearly see the inflows, outflows, the crossover of major arteries and both the arches. Then when we find that these are normal, then 90% of major structural cardiac anomalies can be ruled out. So this is what we look at when we do an anomaly scan. But as I said, I'm not going to go into the technicalities of it. So once a cardiac anomaly is picked up, what is step by step that we do as a fetal medicine consultant? First, we try and rule out any other associated anomaly or the soft marker in the fetus, because we know if there is any associated anomaly or soft marker, there are very, very high chances of chromosomal cause or a genetic cause, right? Even if there is no anomaly or marker, second step would be to do amniocentesis to find out or to rule out any kind of genetic disease association. And then we refer, once everything is ruled out and we know it's isolated structural cardiac anomaly, then we refer this patient antenatally, the couple, to a pediatric cardiac surgeon, whom both the fetal medicine or obstetrician and the patient is going to bombard with many, many questions. And which are these questions which we are also going to ask Dr. Ashutosh today? In any cardiac condition, whether postnatal surgery is possible in this condition, delivery should be done at which tertiary center where we'll have pediatric cardiac surgeon as well as a neonatologist. If a surgery is possible, whether a single surgery or multiple surgeries will be required for this condition. How is the postnatal outcome of surgeries? What is the financial aspect of it? Because we know that these are costly surgeries and not every patient is affording. And what is the long-term outcome? So, of course, both the treating obstetrician, fetal medicine consultant, and the patient would want to know answers of all this. And that's where we are going to trouble our pediatric cardiac surgeon, Dr. Ashutosh, today. So I'm going to start first with one of the very common anomalies which you all have heard about, that's tetralogy of Fallot. And what actually happens in this is, I put the image here first, that there is a ventricular septal defect. This is a normal heart, and this is a tetralogy of Fallot, where there is a defect in this ventricular septum, interventricular septum, so that the aorta is draining blood, both oxygenated blood from left ventricle as well as deoxygenated blood from the right ventricle, and that creates problem, right? So I'll present two cases of tetralogy of Fallot. This is 28 years surrogate mother who came to me at 20 weeks gestation, third grade with two normal children. And on anomaly scan, these were the findings. I'll just tell you that is, if you can make out both in grayscale and in color Doppler, you can see that the aorta is draining blood from both the ventricles. And there is pulmonary stenosis here. And not only that, the aorta is, you can see the aortic arch is dilated, whereas the pulmonary arch is small because of the pulmonary stenosis. Not only that, there is a reversal of flow in the ductal arch. Not going into details again. Case 2, 27 years, non-consanguineous marriage, 21 weeks gestation age, primary gravida, no significant family history. Again, showed overriding aorta with the aorta draining blood from both the ventricles. And there was one additional feature of aberrant right subclavian artery or ARSA in this patient. So keeping these features in mind, now we have Dr. Ashutosh Singh, who is going to help us how to prognosticate about the patients who are antenatally diagnosed with tetralogy of Fallot. So, Dr. Ashutosh, we would first like to know, in such cases of tetralogy of Fallot, first of all, what would be your take? I mean, how are you going to prognosticate? How are you going to, if I send this patient antenatally at 20 weeks of pregnancy with such findings of diagnosis of tetralogy of Fallot, how are you going to start your counseling in these tough patients?
Thank you, Dr. Bela. At the very outset, first, thanks to FOGSI for inviting me for this wonderful discussion. I've always spoken in cardiac surgical forums. So please forgive me if I tend to drift too technical about it. I'll try to keep it as simple as possible for being on. You are extremely experienced, but little bit on the non-cardiac side. So I apologize right at the beginning. But now coming back to what ma'am has discussed, very common scenario. We do very frequently get these referrals about fetal echocardiograms having tetralogy of Fallot. So now TOF is a very common congenital heart disease, and for example, the first case, the two kids are normal. Now, this is a sporadic tetralogy. So not much of a genetic association. It's an aberration in the normal this thing. But the second case is a priming. So there the role of genetics will come into picture. That's first thing we'll have to keep in mind. Second thing is tetralogy at 19 weeks of gestation or 20th weeks of gestation is a disease which is, I mean, this diagnosis is just to be kept in mind. It's an evolving thing, you know. The PS component of PS, what we see the pulmonary blood flow now may not be the same when the baby is born. So I'll have to tell the family that, look, your kid is going to be having a tetralogy. I mean, tetralogy is not one pathology, it's a huge spectrum. You know, it can be plain tetralogy with pulmonary stenosis, to tetralogy with pulmonary atresia, without epicollaterals, with epicollaterals. There are multiple subsets. So at this stage, I will just tell them that, look, your child, your baby is going to have some problem with reduced pulmonary blood flow and a VSD. And to what extent this pulmonary blood flow is going to be reduced, it will determine when we are going to intervene. But definitely some kind of intervention is needed. 100% you need to deliver this child in a cardiac enabled setup, so that when the baby is born, at least we need a good NICU to stabilize the baby, because most of them will be duct dependent to begin with. The PDA will close after 48 hours. After that, all the drama begins. In first 48 hours, nothing happens because most of the time the saturations will be 80 plus, 90. The PDA is flowing. There will be some amount of blood going to the lungs. So child will be fine. If the baby is totally drug dependent, for example, in NICU, then obviously we'll have to start prostaglandins, and there's a well-set protocol in NICU for this. So for the family at 20 weeks, I'll tell them just deliver this baby in a cardiac enabled setup. There will be definitely some surgical intervention needed earlier than later, maybe in infancy 100%, may not be as a neonate, but can happen as a neonate depending on what we see on the postnatal assessment. Therefore, within 24 hours of birth, I would like an echocardiography done by a specialized pediatric cardiologist who understands these things well. And once that discussion is done, once the echo diagnosis is done on a postnatal echo, the neonatology, the cardiology, and the surgeon is going to sit with the family and counsel them about the post-operative course. Till that time, yes. Whether genetic studies need to be done, if a primary, 100%. If it's a sporadic thing, like what you have said, you give the choice to the family, but most of them will come normal because already their kids are normal. One sporadic genetic, I don't know whether Ehsan agrees to this or not, but question is, yes, two normal children, third tetralogy is mostly an aberration. It's not genetic, but primary, yes.
Can I just put one, can I give Dr. Ashutosh, can I just interrupt?
Yeah.
So just one thing is, first take is, the minute the report of tetralogy of fellow comes in the hands of obstetrician, the first thing they think of is termination of pregnancy.
No, it's not. See, I'll tell you, tetralogy is one condition which, if treated well in time, and if it is corrected properly, they have a very good quality of life. I mean, we cannot just say that terminate. Yes. I mean, see, we will be discussing subsequent cases. I will show you some things at the end of the talk, wherein we can tilt that decision later on based on not only the pathology, but socio-economic condition, the society which we live in, and the other parameters of the long-term longevity of the child, if we make also. So all those factors will come into picture, but just the diagnosis alone, okay? I always keep on telling in my surgical forums that fetal echo is a non-invasive investigation with the highest mortality, because the moment you have something abnormal, just terminate.
Very true.
So, you know, that approach has to be kind of, that needs to be revisited.
Yes.
That approach needs to be revisited. And if somebody has a tetralogy of fallow, yes, it's not the end of the road. I mean, we can treat it if it is properly planned. Yeah, we have to plan it for sure. There has to be some thought process, definitely a different thought process which goes otherwise for a normal child. This has to be a little different. We need to be specific where this baby is to be delivered, who all will be involved at the delivery time, how this baby's further course should be planned.
And the finances.
Yes, those things will definitely. And finances, of course. And finances, finance, ma'am, everywhere. You tell me one branch of medicine care which doesn't involve finance. Yes,
Right.
cardiac surgery will involve a little more, but definitely those things are there. And we, as cardiac surgeons, when we are working in a huge setup, we have a huge support from NGOs, government. There are a lot of people who will help. Only thing the patients have to be motivated. Okay,
Yes.
fine.
Yes. Yes.
We have a problem,
Yeah,
there is a solution.
So I
Bella,
think that's a very important
Uh,
message. Yeah.
Can
That's
I make a comment in this,
yeah,
ma'am?
same here. Bella, can I make a comment? Just a clinical comment. That like how we say that in India the incidence of rheumatic heart disease is going down, but I mean Western world also, and even in India today we are getting patients who are having this corrected or surgically corrected phallus tetralogy. You know, they previously they were not reaching even the obstetric career, but nowadays we are getting patients. So thanks to the cardiothoracic surgeon, I would say that these women are getting their prolonged life with a quality life, and of course reaching to the obstetric career. So I won't agree with you also, Bella, that the moment you see a tetralogy of fellow that you go for termination.
I
But
just wanted to
I
give
would
that
still
message.
I would just also agree to you partly because our society has that mentality of not accepting the child who has got an anomaly.
Very true.
So that is also a social and cultural
It
aspect.
was just to give that message to obstetrician that once the report of TOF come, it is not the end of story. It is a correctable anomaly. Please.
Can I make a comment in this?
Sure, sure.
Yeah. So as Dr. Sneha ma'am rightly said, that since because of expert cardiothoracic services now, we are getting more and more tetralogy of phallus which are leading normal lives. And unfortunately, the feeling amongst the majority that if there is a cardiac anomaly terminate, that can be solved if there is proper counseling that is ensured. So if we are able to correctly counsel the patient whether of the outcomes, that will go in a long way to prevent such kind of unwanted terminations.
Very true. So that's the aim of our today's webinar, that to give this message straight that a multidisciplinary approach is what is required for
Yes, ma'am.
counseling antenatally, right?
Counseling, Dr. Bela, I can comment.
Yeah.
Counseling is very important. One thing more, what is the expenses, economy of the patient? The financial status of the patient also depends, because every institution, every government institution is not going to help it. So it is a
As Dr. Ashutosh
point
mentioned,
of
they
concern,
do help poor
the
patients with the
expenditure.
help of funds.
Okay.
Yes.
So
Dr.
how many poor patients he can handle all over India?
Yes.
Yes,
So
sir.
I
even
want to
also
make
the
a
point of
comment on it,
concern.
ma'am.
Yes,
I
sir.
want to make
Yes.
a comment on it because see, pediatric cardiac surgery is one field. See, I have been, when I came back to India in 2013, this was a big challenge because we were the first to start pediatric cardiac program in the Thane district, actually. And so it was the biggest district in terms of population. And ma'am, even today, 70% of our kids, what we operate in Jupiter, are funded, are totally either government funded or NGOs funded. Because you please understand, most of the CHDs are the first babies of these parents, and most of them will be in the early 30s, late 20s, early 30s. That's a standard age group of those parents. And at that age, majority of the parents are not financially so well off to shell out a huge amount of money. I mean, you understand an adult, suppose a person lands up with ischemic heart disease at the age of 55, he's reasonably well settled in his job. He has some PF, some backup, some savings for himself. Consider two people getting married, first child having a congenital heart problem. They will be not even having their EMIs of their houses cleared off. Then they will have an additional burden to cure a child unless and until the society supports them, either government or non-government. So most of them will need, even lower middle class to middle class people will need some amount of support.
The
And
point
which we
taken
give them.
very well. Point taken very well, Dr. Ashutosh. We know that you are there to help not just those who are well off, but those who are not affording those patients also. You have government and other funds with which we can definitely help these patients out. So that message is really, really very, very helpful. I just want to ask you some of the technical things that while counseling such patients, whether if you find that there are findings of cardiomegaly, the size of pulmonary artery based on that, the reversal of flow in ductus arteriosus, that is pulmonary arch, whether all these poor prognostic factors will matter as far as antenatal counseling at 20 weeks is concerned?
Of which only the size of the pulmonary artery will matter. Rest of the things won't matter. Because to me, the size of the pulmonary arteries will tell me how urgently the baby will need some intervention. If the size of the pulmonary artery, and one thing which is missing from here is what is the antegrade flow. For example, if there is some flow going to the pulmonary artery on the fetal echo from the right ventricle, that means it's not it's some amount of antegrade flow means the baby will not need intervention in neonatal age group. If there is zero flow on the side of the pulmonary arteries that are very small, then these babies will need very early interventions for obvious reasons, because they are totally duct dependent. Duct will close in 48 hours, and then they will need some kind of a palliative surgery or maybe very small baby interventions or total correction. So those become high risk. So that, yes, of which only these things matter. The size
And
of the
I think
pulmonary arteries.
also when there is reversal of flow, these are the patients you would want to give prostaglandins to keep it patent. Sir, you are muted. We can't hear you, Dr. Ashutosh.
I think
Correct.
his
Correction
device,
probably interrupted.
his device volume has gone low, I think. Now,
Maybe interrupted.
Yeah, Dr. Ashutosh.
He's unmuted, but then the volume of the device.
We can't hear. Now, please unmute. Please unmute. Please unmute, Dr. Ashutosh.
Yeah, now he's
Volume is, can you make your volume full? On your device, the volume?
He's saying the volume is full.
We can't hear you.
No, but then that sound speaker icon, no, you have to click. I think that sound volume has gone down.
My
Hemant,
connectivity is
that
Sir,
team,
you can try to rejoin, sir.
Yeah, sir, you can.
You can refresh the thing.
You can disconnect and connect again, I think.
Disconnect and connect, please.
Okay, so a few of the points we have already discussed, and those were very, very important pointers that, you can counsel these patients that they can be taken to the term and can be operated upon, provided we do an antenatal consultation with pediatric cardiac surgeon and the geneticist, of course. We are not going to skip that genetic part. Dr. Eshan, we are going to come to you. And in my practice also, and as soon as any anomaly is picked up, we always counsel the patient, do amniocentesis and send it for genetic testing to rule out genetic cause for the and then only we refer these patients to a pediatric cardiac surgeon. Now, in this case, I just want to ask now, once Dr. Ashutosh joins, whether some of the poor prognostic markers which are showing that the heart is failing and there is high drops, etc., what is his take? So let him just join and then we'll till then, Dr. Eshan, you want to give some inputs in cases of tetralogy?
I would like to ask one question.
Yes.
Is there any facility for intrauterine correction at this stage?
No, I don't think so. Intrauterine surgery, surgical correction of cardiac surgery is no. Where people have been doing spina bifida, meningocele surgeries, that too internationally, and not yet in India. But the cardiac surgery, no. Intrauterine surgery has, because the physiology is entirely different, intrauterine and extrauterine. So no.
Okay. Thank you, dear. Okay.
Dr. Ashan?
So in the meanwhile, I'll just make a few comments on tetralogy of Fallot. So basically, for any cardiac anomaly, it is very important first to rule out whether it's an isolated cardiac anomaly or whether it is associated with other malformations. That will actually decide the prognosis. If in a case of isolated tetralogy of Fallot, where genetic testing has turned out to be negative, probably you are safe with counseling the parent that if the surgery goes well, the child will be okay.
Right.
As opposed to that, if there are associated malformations, which is more likely taking the diagnosis towards a syndrome, at that point genetic testing becomes extremely essential to find out the cause and accordingly counsel. So most, as in all congenital heart defects, most common causes are the aneuploidies and the copy number variants, the microdeletions and duplications. So probably that will be the first line of genetic testing in this case. If it turns out to be a Down syndrome or Edward Patau, then straight away we have a very strong cause to counsel the family that look, along with tetralogy of Fallot, we expect other issues also coming up postnatally. So the family is in a position to take a decision of termination. Okay.
Hello,
But
am I audible now?
Yes, sir.
yes,
sir.
I think the
Very
sir
much.
has joined them.
Very much.
I'm sorry. I don't know. There's something in my laptop which is telling that they can't detect the audio. I've taken it on my mobile.
Okay.
So
Yes.
yeah.
So
So I'm sorry for this technical glitch.
that's fine. That's fine, sir. So I just had few queries that suppose with such tetralogy of Fallot, there are obvious signs of poor prognosis, like the tricuspid regurgitation, AVEV reversal, inductus venosus, which is telling that the heart is failing. Sometimes even high drops. Then what? How would you counsel?
No, if the anatomy is good, then most of the hydrops is again it's an additional risk factor. So we'll have to counsel it in that category that this baby is going to have a rough time postnatally. But if all these factors are not there, for example, if the pulmonary arteries are good size, there's a good antegrade flow, and tricuspid regurgitation, yes, again, tricuspid regurgitation is one bad sign because that means tricuspid valve is not functioning. And for long-term outcomes of this patient, tricuspid valve has to function normally. See, when we talk about post-operative course and long-term outcome of these patients, your right ventricle's future is depending on how when the patient's future depends on how the right ventricle's future is. So here tricuspid regurgitation is a negative factor. Like I don't want the tricuspid regurgitation to be present if I want a good long-term outcome of my tetralogy patient. So that is the reason I suggested that good size pulmonary arteries, some amount of antegrade flow, good size tricuspid valve, good size right ventricle. These are additional medical pointers towards good prognosis.
Right. Then there are many of the babies who have any kind of structure anomaly, including cardiac anomaly, are growth restricted. They are less than 10 centile. So whether that additional factor adds to the prognosis of cardiac?
No, not that much, because see, for example, ma'am, if you have prematurity related issues or what they say, low birth weight, like the growth retarded babies, they will definitely have their own share of ICU challenges. But I mean, those are all additional risk factors for their ICU recovery.
Right.
Malnutrition is an independent risk factor for poor outcome, anyways, for anything. I mean, be it a small VSD also. And most of these tetralogy babies tend to be normal weight or slightly on the overweight size. They are quite chubby, actually. So those things usually don't matter here.
Okay, this one normal thymus I put here mainly for Dr. Eshan, because we know that in TOF many a times 22q11 deletion, Dijot syndrome is one condition which can be associated in which we can antenatally find that the thymus is smaller in size than normal or absent or very hypoplastic. In that case, of course, this is one of the pointer. So in any which case, we are going to do a genetic test to rule out not only trisomy 21, but Dijot syndrome. Right. So this was just one of the prognostic marker that I had put here. And Dr. Ashutosh, these days, not only second trimester, but we pick up some of the major cardiac anomalies in first trimester as well, because we look at the inflows, outflows, the X sign, the crossing over of major arteries, etc. So whether earlier diagnosis in the first trimester versus second trimester diagnosis, does it change the prognosis if it is picked up at, say, 14 weeks?
As a surgeon, won't match, but as I mentioned, the earlier it is diagnosed, the chances that the baby will have a severe subset of the pathology is going to be high.
Right, right.
So it's an evolving thing. The heart is that growing that time, the outflow tracks, etc., will be evolving as the time passes. So if I pick something up very early, I'll explain you in your subsequent when you discuss a VSD, how a course of a VSD changes, as the pregnancy progresses. So similarly, if your pulmonary arteries are extremely small, they will definitely chances no flow, no grow. So if the flow is very restricted at that point of time, the size at birth is going to be very small, and then they will adversely affect the outcome if such things happen.
So I think we have learned well about the counseling of tetralogy of Fallot and which are the poor prognostic factors and how to counsel the patient with the help of both our pediatric surgeon and the geneticist. So we go on to the second anomaly, which is again not uncommon, hypoplastic left heart syndrome. As you can see here in this, there is completely non-developed left ventricle. And therefore, the aorta is also not developed, it's stenotic. And this was a patient, 31 years old, second gravida, non-consanguineous marriage with first female who's normal without any structural anomaly. And on anomaly scan, this was the picture. As you can see, the left ventricle is almost not developed, and the apex is formed by the right ventricle. And as you put on the color Doppler, you can see that there's flow only on right side and not at all on the left side. And the pulmonary artery can be seen, but the aortic arch is absolutely small with reversal of flow. And here, again, you can see that the pulmonary artery is dilated, but the aortic arch is very, very small with reversal of flow. And when you look at the biventricular function, the left ventricle is almost not contracting, whereas right ventricle, you can see contracting here. So you know for sure this is a hypoplastic left heart syndrome. Now, I'm just going to put this recent study which tells us how we prognosticate, and then we are going to throw our questions to Dr. Ashutosh. So it tells us that there is a good prognosis in case of congenital VSD, PDA, ASBS, GAPVC. But when there is a single ventricle or complex CHD, the correction, the adult survival is 50 to 60%. And especially in hypoplastic left heart syndrome, it is less than 10%. And it also tells that when there is only one ventricle which is functioning, or when the aorta is small, either of the tract is, very, very stenotic, there is duct-dependent lesion. These are all findings that we find in hypoplastic left heart syndrome, which is a very, very poor outcome. So here, we really want to know whether any postnatal surgery is possible in such condition where the left ventricle is not developed at all. And then, of course, those all common questions. So, Dr. Ashutosh, over to you.
Thank you. Now, see, when it comes to hypoplastic left hearts, ma'am, the decision worldwide among surgeons is very clearly dichotomized. Some people who believe in offering surgery to these patients, and some people who are very clear about not offering surgery to these patients. And a lot of factors are involved when you choose either. Okay, so my suggestion is I am a person who will go with a very practical approach, and we are talking about Indian scenario. Now, if delivery, yes, tertiary care center, I totally agree that it has to be in a tertiary care center, no doubt about it. Surgeries, multiple surgeries will be needed, and outcome, see, Norwood surgery, which is a stage 1 palliation, Norwood itself has got a mortality in the best of the best centers up to 15%. And the success of a Norwood procedure depends totally on the expertise of the team which is treating it. And for a team to become an expert, it has to do a certain amount of volume of cases every year. It's not only the surgeon, the cardiologist, the nursing staff, the people, the anesthetists, the intensivists, everybody has to be tuned to how to manage an Norwood baby post-operatively. And if you don't do a particular volume and number of cases, surgical outcomes are going to be universally dismal. If you are not, so I mean, if you see good centers in America, not all of them will be licensed to do Norwood operations. Norwood operations are only permitted in certain centers which have been doing Norwood for quite a number of years. And all the patients are referred to those centers so that their cumulative experience keeps on increasing and they slowly and steadily understand the nuances of how exactly these babies need to be managed. So surgical outcome.
Any personal experience here about this condition?
The patients don't. I won't do Norwood because it will cost them 7 to 8 lakh rupees.
Right. And the outcome is still not.
And then after that also we are having, see, if I tell a person, now for example, again, a potential mother who comes to me, and if I said, look, the baby is never going to be normal, the baby is going to be sick as soon as he is born, the baby will need neonatal cardiac surgery with a very high risk, very dismal outcome in the long term, because most of them will never see adulthood, as you have already shown in your slide. So adulthood is hardly anything. They will the best of the best centers also, they will succumb by the age of 27, 28 years. That's the best outcome. So if the life of a child is restricted to 20, and during these 28 years also, they will have frequent admissions, they will need multiple surgeries, they will have very poor exercise tolerance, they will not be as normal school children, they will have very poor exercise. The quality of life is going to be definitely compromised.
Right.
So at that stage, patients will say, okay, fine, we agree, thank you very much, and they'll come back to you and request abortion.
Right.
So, and this is one pathology I would not say no, because it is a fact, it's a philosophy. Okay, fine, if you don't, I mean, you have one decision now, feel bad about it for some time, and then you get over it, rather than this whole thing chronically running for years and years, and you will be drained with your finances as well as you will be mentally unstable.
So
And
again,
losing somebody at 27 years of age is very painful.
Yes, true.
So
So
bond is never developed. If you lose somebody who is not yet born, it's okay. But if you lose somebody at 27 years of age, relatively, it's a very, very tough time for the entire family.
Completely agree. So point taken very well, Dr. Ashutosh here. As against tetralogy of fellow, where we say we should counsel and try and save each and every baby because we have treatment available. As against that, HLHS, because we know the prognosis is very, very poor, the postnatal surgical outcomes are not good, multiple surgeries, and still the quality of life is not good with a huge expense. If the patient wants to terminate, yes, we can give that option of termination of pregnancy.
Yes,
And
yes.
sure
I mean, we will be fair. Yes, we in India. Yes, I mean, another thing which I want to, ma'am, get to your point is most of the successful Norwood programs are federally funded. They're government funded.
Yes.
Nobody in the Western world, or either they're covered with insurance. In India, government is not in a good position to support Norwood. Neither any of your insurance policies will cover congenital defects, and expecting a patient to spend that much amount of money on like, it is just not fair to the family. It's only science driven medical heroics. I will not support that practically, ma'am. It's not a great idea.
Very true. So we have already discussed two contrast anomalies. We now move on to the atrioventricular septal defect, which is again a very, very common AVSD, as we call it. And as you can see in this figure, the crux is absent, right? And because of that, there is a defect. And because of that, both the valves will be at the same level. So here there is a patient, 29 years old, non-consanguineous marriage, conceived with infertility treatment, 20 weeks, 6 days, second gravida, first missed abortion. And she was sent at 20 weeks, 6 days. As you can see, there's nothing here. Crux is completely absent. Both the valves were at the same level. As you can see here, there should be an offset between the tricuspid and mitral, which is lost here. And then this is what I'm not going to go into technicalities. As far as associated findings are concerned, unfortunately, in this patient, we had unossified nasal bone. And we know that when we have such a marker along with AVSD, it's a very, very common cause is Down syndrome or trisomy 21. So in this particular case, the prognosis is very, very poor. But if there is no such associated finding, if the genetic test that we always do in AVSD rules out common chromosomal or genetic conditions, then again, our question to Dr. Ashutosh, how are the postnatal surgical outcomes in cases of AVSD?
Now, AVSD is, I mean, I always tell in multiple fetal forums that it is something which, as a surgeon, if you give me an ABSD with Down syndrome, the quality of surgical repair is going to be fantastic as compared to a non-Down's ABSD.
Is it?
Okay.
Oh.
Yeah, I'll tell you the reason for it. Let's first discuss all these points. Whether postnatal surgery is possible in ABSD, yes, very much. The timing of surgery is in infancy. It's not in neonatal age group. I would rather, most of the ABSDs are very well treated between 3 to 6 months of age. And ABSDs who are extremely symptomatic, who are very fragile, and who are very sick in less 3 months of age, the long-term outcomes of such surgeries are going to be poor. Weight less than 3 kg and age less than 3 months, the long-term outcome of these patients after surgery is problematic. But if you can do a good repair after 3 months of age or more than 3 kgs, the postnatal surgical repairs are good. Delivery at a tertiary care center, we would like to, if it's an antenatal diagnosis, we would like to know as soon as possible what is the state of the ventricles, how is the AV valves developed, what is the kind of regurgitation, because those are the markers which will tell me how much is the urgency of surgery. If a AVSD with severe AV valve regurgitation is there, then I would like to go in early, and I'll be careful about planning surgery for these children, because if I have to go less than 3 months, as I mentioned, with severe AV valve regurgitation, then the valve's quality is going to be not that great, and the long-term outcomes depend on how good are the valve how developed to give me a very good repair possible. So if yes, single or multiple, a good surgery in infancy is fair enough, but there is definitely some chance of reintervention in life later on the left AV valve most of the times. The regurgitation, if it is not totally addressed at the first surgery, many times it's a very critical balance between how much to fix the regurgitation and not at the cost of stenosis. If you keep on repairing the valve to get an ideal valve which coax well without regurgitation, you may land up with a stenotic valve. So you might have to accept some amount of regurgitation, which may be a reason for reintervention later on in life. Outcome, again, from a pure cardiac perspective, outcome is good, but it will also depend on what are the other chromosomal anomalies, overall development of the child. I mean, syndromic AVSDs are complex AVSDs wherein there are a lot of other issues with the valve. Apart from the leaflet problem, there can be single papillary muscle, there can be annular narrowing. So all those factors will make a difference. Another very unique subset of AVSDs are unbalanced AVSDs, wherein one of the ventricles is small. So there they will have a single ventricle approach, and we know in your slide that the single ventricle patients fairly not do well. So those I will not categorize. They are a complex subset of AVSDs tilting towards single ventricle physiology, where the outcome is not that great in the long term. Financial aspects, yes, but it is manageable. Syndromic children, if they are syndrome downs, severe downs, just to share with you, a lot of NGOs are very reluctant to help them because they know that the amount of money which they donate to these children, long-term outcome is not going to be that great. There are certain NGOs we have worked with, they are very categorical that we will not help a syndromic child. We will help a person who is potentially, having a very good prognosis is one cardiac surgery, which is a thing which we need to be considered. And therefore, these AVSGs, a genetic assessment is mandatory, and we need to tell the family that it is a syndromic AVSG or a non-syndromic AVSG, and based on those things, we have to counsel. Long-term outcome, as I mentioned, it all depends on the fate of the left AV valve, how the left AV valve behaves in future. Most of the other factors will be taken care of during first surgery itself.
Okay. Great. And you said that means you have some patients with Down syndrome in whom you have operated and the results.
Oh, lots of them. Lots of them. I told you technically, and coming back to the initial point which I made, why Down's AVSDs are easy to repair? Because their valves are quite nice and thick and myxomatous. So my sutures will hold on very well. Oh. If you give me 3 kg Downs versus 3 kg non-Downs AVSD, I can 100% tell you this Downs AVSD repair is going to be better in a non-Downs AVSD. The non-Downs AVSD valves are like jellyfish. They are so fragile and flimsy. If I take a stitch, it will tear. But if I take a Downs baby and I put stitches through those valves, they will hold on to any pressure post-operatively. So it's a very contrasting thing. It's a very contrast thing, which I always keep on telling. The Downs baby AVS repairers are very good because they are all most of the times are Rasteli type 3, type C. Now, type C Rasteli AVSGs are very easy to repair.
So just for our information, we would like to know these Downs were diagnosed antenatally or postnatally they were diagnosed?
Few of them are diagnosed antenatally, but again, if the patients are from rural part of the country, rural India, they will get suspected postnatally by the pediatricians. But if they are coming from Mumbai and around, yes, a lot of them have at least suspicion is there, and then they do the. Most of the patients when they come to me, they will have some report done already. So I do ask them antenatally, so they'll say, "Oh, suspicion was done, but it was we confirmed it."
Just
So
asking
a
because
lot of them are in a phase of denial.
yes.
The denial component is also there. So they will say, "नहीं hua tha, फिर बाद में हुआ ये वो तो." That we understand from the way patient talk to us.
Because just ask you because there'll be a set of patients. Number one, with Down syndrome picked up antenatally, they may not continue with the pregnancy. That is one thing. Second thing, even if they continued because it is Downs, they wouldn't agree for any surgical correction because there'll be a set of such patients. So
Madam,
I
I
was
totally
just
agree. In an urban setup, as you are rightly telling, if somebody says Downs AVSD, they will easily never come to me.
yes.
They will go and confirm it from a genetist, and then they will go ahead with the termination. But if the baby is coming from this thing, or as I mentioned, if there are doubts, they are in a phase of denial, then they will land up where termination is not possible, and then they will come to.
Right. So again, a lot of information that we got from this case. Thank you so much, Dr. Ashutosh. Moving on to isolated muscular VSD, which is one of the very, very common the defects that we pick up in antenatal ultrasound, as you can see in this figure. So this is the muscular part of the ventricular septum. And when there is a defect in this, now, as the heart is developing, there would be some defects that you find, some tiny ones, sometimes some larger ones. And how they fare, we have to see through the follow-up in the antenatal period. So I'm just showing you one scenario where you can see clearly there is a defect in the muscular part of the septum. Now, as far as isolated, when I'm talking about an anomaly at present, I'm talking about isolated structural cardiac anomaly without any associated structure anomaly or marker or any genetic cause. We have ruled out genetic cause. And then it's an isolated muscular VSD. Now, this is what we usually follow, that when there is isolated muscular VSD, well, the outcome is usually, if it is small one, less than 3 millimeters, well, it is likely to close spontaneously either throughout the pregnancy or in the first postnatal year. So usually the prognosis is good. But if it is a large one, and we know of one such last year in one of the celebrity, a huge VSDs also, how is the outcome that we would like to know from Dr. Ashutosh? And I'm sure he has a lot of experience in this. So yeah.
VSD is the commonest, the pathology which we operate as a pediatric cardiac surgeon. So yes, as you are rightly telling, 2-3 factors are there. But if the VSD is small VSD or muscular, see, two things matter actually when you talk about the chances of spontaneous closure. One is the size, and second is the location. For example, if there is size, so the VSDs which are small, like, there's a gradient of more than 60 across the VSD, they can be followed up if there are no symptoms or there is no evidence of LALB dilatation on echo. There can be followed up if the child is gaining weight. And if they are close, 80% will, if they are destined to close spontaneously, 80% of them will close during the first year of life. And if they don't close by that time, then the chances of spontaneous closure slowly reduces over a period of time. They will not close. Okay. Second thing is the location. So perimembranous VSDs or muscular VSDs, they have high chances of spontaneous closure. But if you have a VSD in the inlet septum or subarterial VSDs, they will never close spontaneously. They will never close. Irrespective of the size, they will never close. They need to be addressed. They need to close. So that is one thing. So whether postnatal surgery is possible, yes. In fact, if it's an isolated muscular VSD, they can be even closed by non-surgical methods nowadays with devices. So we don't even have to go inside and arrest the heart and do it surgically. You can safely do it via cardiology techniques. delivery at a tertiary care center with a pediatric guardian, it's not mandatory, but I would rather prefer to have it to explain at least the family what is the course of action we are planning, because none of them will be so sick in the neonatal age group so as to warrant surgery unless they are associated with other anomalies. For example, a lot of these VSDs which are very diagnosed very early, as the pregnancy evolves, as the heart develops, they will develop outflow tract obstructions like hypoplastic arch, coarctation. Now, those are the subsets which will need immediate intervention in the neonatal age group. Isolated VSDs, they will not need, I mean, in America and all, they still close it in neonatal age group, but clinically it's not indicated. Okay, so they will be treated, ideal time of treatment will be around 3 months of age. We can easily close it. If yes, single surgery, yes, single surgery is enough. If you close the VSD, if there's no residual shunt, we don't need to go in again. Financial aspect, most of the NGOs and government scheme will cover VSD closures. So if the patient is poor, still no need to worry. They will be taken care of. Long-term outcome, excellent is the word, excellent. They are one-time, fully curable problem. There is no further follow-up needed after 5 years. There is no medications needed. They are having fantastic quality of life, good education. I mean, it is one thing which you should never ever tell your patients to lose hope. It is one thing which should be corrected, and they will have excellent quality of life.
Right. Thank you so much. So this is one anomaly where, we are very, very hopeful, and we always counsel patients positively that yes, we will follow them up throughout the antenatal period, but they have very good outcome postnatally. We have pediatric cardiac surgeon like Dr. Ashutosh and more. So they will definitely help our patients get these babies treated surgically, and will have a very good outcome, as we can come to know. So the last anomaly that I'm going to talk about today is not a very common one, but yes, not uncommon as well. Abstain anomaly. Now, what happens here? We all have heard about it, that there is the tricuspid valve is more apically inserted, and so there is atrialization of some part of ventricle, and this tricuspid valve is also not functioning well. So here was the patient now. This was 24 years old, non-consanguineous marriage, referred for hydrops fetalis. The obstetrician called me specifically, there is hydrops, and I have done some blood tests and all, patient is RH positive, and there is no cause, and I don't know what is the cause of this hydrops, and was sent at 25 is 5 days. Now her obstetric history, there was bad obstetric history. First pregnancy, there was bleeding at 18 weeks, followed by abortion. Second was preterm delivery at 26 weeks. Male died in NICU. No papers were available, no antenatal ultrasound done. And currently, the 19 weeks anomaly scan, which was done outside, was not showing any kind of anomaly. Where the obstetrician had already done the blood group was positive, torch negative, indirect Coombs test was negative. So that cause was out. So the baby had this ascites. Sorry. Had ascites, and along with that, there was subcutaneous edema. So and there was pleural effusion as well, as you can see here. And in this clip, you can see axial image. There is a cardiomegaly, and you can see as we go down, there will be ascitic fluid, which you can see in the peritoneal cavity. And if you look at the heart closely, this is what is seen. The offset, we can see that the septal leaflet of the tricuspid is tethered. And if you look at the offset between the mitral and tricuspid, it is very, very high. It's 8.5 millimeters, which should be normally just 1 to 2 or 3 millimeters, not more than that. And so this is what you can see in the clips as well as image. And of course, on color Doppler, it was a regurgitant tricuspid with the flow of regurgitation arising from the middle of the ventricle. There was tricuspid regurgitation, and there was reversal of flow in the ductus arteriosus as well as ductus venosus A wave reversal. So, and with hydrops. So with so many signs of, poor prognosis, this patient never wanted to continue the pregnancy. Now, here again, we have all our doubts whether when the antenatally the tricuspid wave is so bad with regurgitation, with so many signs of cardiac failure. What is your take, Dr. Ashutosh, whether we can help this patient?
There are two factors, ma'am. Now, again, like tetralogy Epstein is a spectrum. Now, there are five defined varieties of Epstein. Type A being the simplest one, and type 5, what you have described today now in your reports. They are extreme. So, what happens is we have to understand that the right side of the heart, it's not just a disease of the tricuspid valve, it's a disease of the entire right heart, right from right atrium, which is hugely dilated, right ventricle, which is atrialized. Now, what proportion of your right ventricle is atrialized will determine what is the amount of actual right ventricle available to this patient for future. Because that whatever is atrialized even after repair, that will definitely not sufficiently contribute to the antegrade cardiac output. And based on whatever is a small amount of RV available, and that will determine how much is the pulmonary blood flow going. Because pulmonary stenosis is an acquired phenomenon in Epstein. Because there is hardly any blood. If everything is going back to the right atrium, what is left to go into the lungs? And as a result of which, to supply the lungs, there is a reversal of blood flow in the ductus arteriosus of fetal echoes. So all those things, once you have a patient, I mean, post-operatively, yes, you're again question, where is the postnatal surgery is possible? Now, Epstein's present in two. It's a typical bimodal presentation in postnatal life. One is infants, neonates and infants, and other ones is the older children around 6 years, 7 years. And even I have operated adults in Epstein's which had no symptoms till they become 25, 26 years of age. So there are two well defined. The ones who present very early, neonatal Epstein's or young infant Epstein's. Now, these are the ones who have those type 4, type 5 disease, wherein the right ventricle is hardly developed. They become very symptomatic as soon as the duct closes because there is no pulmonary blood flow, they become blue. And we have to offer them the single ventricle pathway where the prognosis is very poor, as you saw in the single ventricle group. So there we have to go ahead with the single ventricle pathway because they are not repairable. Most of these valves are not repairable. Even the Stans operation, which is described for neonatal Epstein's, has got a heart mortality as high as 20% in the best of the centers. So again, those things are gone away. But if the baby grows up into a child or a young adult, those in those cases, postnatal surgery is possible. We do cone repair of the tricuspid valve. I myself have done a few, and their prognosis is very good. They live a normal life, and they just need lifelong surveillance. For of course, these valves are basically abnormal. We have made them normal by certain surgical strategies, but they will definitely have some chances of future tricuspid valve re-intervention may be needed in postnatal later on in adult life. They are also known for arrhythmias. Most of them are associated with Wolff Parkinson White syndrome. That is a well-known association with Epstein. So they will need a cardiology follow-up for the rest of their lives. They may need catheter-based ablations in life for arrhythmias, supraventricular tachycardias. So all those things, they need lifelong surveillance, but they have good quality of life. Delivery at a tertiary care center, yes, it has to be done because of the severity of disease is unpredictable. If the baby is stable, you discharge the baby, let them follow up with the pediatrician, and then come up for surgery as and when needed when the pediatric cardiac team decides. Multiple surgeries, if you are going for a stance or neonatal or a young infant intervention, they will need multiple surgeries. Single ventricle pathway, 100% they will need multiple surgeries. But if you're operating on a bigger child, then may not need now, but later on in adulthood, some reintervention might be needed, some cardiology reintervention might be needed. How is the outcome? We have already discussed that. Financial aspect, more the number of surgeries and intervention, it will be definitely having its own financial implications. So yes, it will have certain financial implications on the family in the long term. But long-term outcome, as I mentioned, depends on A, your right ventricular architecture, 2, the quality of your surgical repair, 3, the arrhythmias, and the associated left ventricular dysfunction, which happens later on in these patients.
Thank you so much. That makes the things very, very clear. So there's a spectrum and milder forms, and with good ventricular function, we'll have a good outcome.
Yes.
Whereas on the other side, where I showed the case, the prognosis is as such going to be poor. So there can
They
count
will be single ventricles basically. So
It is a single ventricle. So, and there are some conditions where you feel that the antenatal diagnosis is must, without which postnatally immediately surgery is required. So, which are these conditions you feel must be diagnosed antenatally?
So I would love to diagnose most of them antenatally to be able to guide the parents well. But TGAs are easily diagnosed antenatally, but don't need emergency surgery. They need surgery in the first 15 days, even 3 weeks of life. They are drug dependent sometimes. Sometimes they are. See, it all depends. Drug dependency in TGA will depend on if the ASD is big and if there is an associated VSD. If there is a good size ASD, then we need not start prostaglandin. If there is a small size ASD and no VSD like intact IVS, then we will need some prostaglandin for a couple of days before we take him for surgery. So it's not that as soon as we diagnose you, within hours you have to take it for surgery. But TAPVC is yes. TAPVC is one condition which is a genuine surgical emergency, and their prostaglandin has got no role. There's only one role, and that is surgery, surgery, surgery. There is no role, and the problem with TAPVC is it is one condition which is very frequently missed on antenatal scans.
Exactly.
So it is a very contrasting thing, because the baby which I was operating today morning, the first question he asked me कि सर हमने तो 19th week में पूरा सबसे एक्सपीरियंस सोनोलॉजी से कराया था, फिर एक ऐसा मिस हो गया. Then I had to explain them कि boss, this is not the way. It is one. This the flaw of the nature of the disease and the inherent limitations of the test are there. I mean, it's an operator-dependent investigation. Then the condition of the this thing. So there are too many factors. You cannot be foolproof here. So this is one condition where invariably the family feels that the doctor has missed it. No, it is not that. It is more likely to be missed on an antenatal scan, a TAPVC. But if a TAPVC is most of the times not even having any clinical signs, when the baby is born, he will be having respiratory distress. Most of the time will be treated as primary pulmonary hypertension, some meconium, because if the baby has some meconium aspiration, they will keep on treating. And in that bargain, they keep on giving drugs like oxygen. They give vasodilators, pulmonary vasodilators. I mean, that just kills the baby.
Right.
So strong index of suspicion is needed for a TAPVC to be diagnosed at birth by the NICU team. Because if you start all the attempts which are done to treat PPHN are detrimental to the baby when you have a TAPVC, which actually gets the baby in shock, and then they diagnose if nothing is working, अरे शायद TAPVC होगा, and then they do an echo, and there they land up that the baby is already in shambles when they come to us. A neonate, the saturation will be 40, BP will be hardly recordable, lactate will be 15, 16, and then how do I operate on such children? That is the problem.
Thank you so much for brilliant inputs, Dr. Ashutosh, and we learned so much about the spectrum of diseases, antenatal diagnosed cardiac anomalies. It was really so engaging and so interesting to discuss about everything. So we've seen the best of the results in isolated muscular VSD, to good results in TOF, to spectrum of, in case of Epstein anomaly, we have milder to severe varieties, and AVSD, which is again operable and all. So all in all, it was a very productive discussion. Thank you so much, Dr. Ashutosh.
Thank you, madam. Really appreciate everyone for their patient listening. I really appreciate, and thanks FOGSI for this.
Thank you so much. And now we have, last but not the least, Dr. Ishan, who is going to help us with the genetic association with cardiac anomalies. So Dr. Ishan, we are all looking forward to hearing you. I'll just stop sharing so that can I request?
So, yes, madam. Sorry.
Yeah.
Dr. Varsha, our esteemed chairperson, we would like you to please introduce Dr. Ishan. I think Dr. Bela, ma'am, you can introduce Dr. Ishan.
Okay, Dr. Varsha is not there. So
Yeah.
Dr. Ishan is a clinical and metabolic specialist, a clinical geneticist, MD Pediatrics from St. GS Medical College, Mumbai, and is clinical geneticist with Lilac Insight at present, with life membership of Indian Academy of Pediatrics, Society of Fetal Medicine, and Mensa in India. Well, he has interest in syndromology, inborn errors of metabolism, immunity, etc. And today we have roped in here to know more about the clinical genetic association of these cardiac anomalies and how we can, kind of based on the history and the findings and everything, how we can go ahead and find out the genetic association. And Dr. Eshan, over to you.
Thank you so much, Bela ma'am, for the kind introduction, and good evening to each one of y'all. And thank you for removing the time and attending this wonderful academic feast. And at the outset, I would like to thank FOGSI and ISPAT for inviting me to share my views about the geneticist perspective to fetal congenital heart anomalies. So I'll just share my screen. Is my screen visible?
Yes, yes.
Yes. Okay. So the good thing for me is that a lot of the things that I was going to discuss has already been discussed. So a strong foundation has already been laid by Dr. Bela and Dr. Ashutosh sir to for me to build upon. So I'll try my best. So my role is now to give you a geneticist perspective on cardiac anomalies. How does a geneticist think when a child or a pregnant woman with a fetus having a congenital heart anomaly comes to us? Yes. So why do we screen for congenital heart disease in the antenatal period? I think this point has already been covered. It is the most common major congenital anomaly, around 1% incidence. 50% of the deaths due to congenital anomalies are due to congenital heart disease. And like Dr. Bela ma'am already rightly said, that prenatal diagnosis of a congenital heart disease improves the postnatal outcomes because it gives family time to prepare. It gives time for the doctors to prepare the case so that the child is delivered, the mother is delivered in a proper tertiary care setup and in a proper NICU facility. So whenever a patient comes to a geneticist, these all questions come to mind. First question is, what is the problem? So that deals with the diagnosis. Second, why did it happen? So that is the etiology. Third is, what's the prognosis? After which, once we have answered these questions, other questions which probably other specialties don't think, but a geneticist has to think in this manner. Will it recur? Are other family members at risk? And what is the best treatment option available for which I can counsel the patient, whether curative or palliative? So we'll go through these questions one by one. So what type of lesion, cause, that both of them would lead to appropriate genetic testing, after which we'll prognosticate, we'll assess the recurrence risk, we'll do cascade screening to look at others who might be at risk, and to design treatment options. So what type of lesions? Already, I think discussion has been done. But just to give a little overview, this is the Botto classification in which congenital heart anomalies are divided into broad 8 types, which is the anomalous pulmonary venous return category, the conotruncal defects, which includes the TOF, the DORVs, the interrupted aortic arch, the truncus arteriosus, the septal anomalies like atrial septal defect, ventricular septal defect, the AVSD group, the left ventricular outflow tract obstruction group, which includes HLHS, aortic stenosis, bicuspid aortic valve, coarctation of aorta. The right ventricular obstruction, outflow tract obstruction group, which includes the pulmonary artery stenosis, pulmonary valve stenosis. It includes Epstein's anomaly, tricuspid atresia, the heterotaxy group, and the complex group, which includes the combination of all these. Okay, so once we know the lesion, so the lesion basically is determined by the fetal medicine, the obstetrician, and the fetal cardiologists, because they will be the ones who will be doing the detailed anomaly scan or the fetal echocardiography. So after knowing the lesion, now the next step is to know the cause. So now in the cause, one has to understand whether it's a genetic cause or a non-genetic cause. If genetic, whether it is isolated or syndromic, and what is the inheritance pattern. So let's revisit a little bit of genetics in this space. I will assure that I won't take much of time on this slide. So we have cells. In the cell is nucleus, and there are chromosomes, and chromosomes are nothing but long stretches of DNA. So a genetic disorder can be either at the level of the chromosome, or it can be at the level of these stretches of DNA, or it can be at the level of at a very particular point of DNA. So when it is at the level of the chromosomes, it is most probably the numerical anomalies are called the aneuploidies, whereas the structural anomalies, these are the translocations. When it is at the level of the stretches of DNA, they are called the copy number variants, which means either there is a deletion of particular region of DNA, or there is a duplication of particular region of DNA, which leads to either deletion or addition of few critical genes leading to the phenotype. Or it can be at a single point at the DNA, which is known as the single nucleotide variant. So if we look at the spectrum of disorders causes in congenital heart disease, we will know that most of them are, as of now, unknown. So this actually falls into the broad area of multifactorial disorders, okay, where there is a combination of genetic causes which are yet unknown, as well as environmental influences, which together lead to the phenotype. But these things, these multifactorial disorders, they constitute more than 50%, almost 60 to 70% actually. The rest 30%, if we look at the division, we would see that mostly they are made up of either the chromosomal abnormalities or the copy number variants. The chromosomal abnormalities, as we all know, the common aneuploidies, Down syndrome, trisomy 21, trisomy 18, 13, the monosomy X, Klinefelter syndrome. These are the aneuploidies, which are commonly implicated in the congenital heart disease. Along with that, there are few copy number variants which are also implicated in congenital heart anomalies. So the most famous that we all know is the 22q11.2 deletion, that is the DiGeorge syndrome. But we should also know that there are a lot of other microdeletion syndromes which are associated with congenital heart anomalies, because this becomes important, this knowledge becomes important while we are testing in the pregnancy. Along with these chromosomal abnormalities, almost 5 to 10% are single gene disorders. Okay, and with the advent of next generation sequencing, we are coming to know that more and more single gene disorders are now being implicated in the congenital heart disease. So the two slides are going to be a little busy, but the entire point of showing this slide is basically that in every group we will autosomal causes copy type of physiology, or it can cause a non. If we take AVSD for the example, so we all know that in AVSD, trisomy 21 is very commonly implicated as the most common cause, and we would test for trisomy 21. But along with that, we should also keep in mind that there are other microdeletion syndromes which are associated with AVSD, as well as monogenic disorders like CHARGE syndrome, Ellis-Van Creveld syndrome, Holt-Oram syndrome, Noonan syndrome, or Smith-Lemli-Opis syndrome. Along with that, if you look at the most right-hand side, just let me start my pointer. If you look at this column, basically it is showing that a lot of these genes are now, mutations in these genes are now getting implicated in causing congenital heart disease. So these genes are mainly the transcription factors which are active during development stages. So with this next generation sequencing, we are now identifying a lot of these genes which only in isolation are leading to congenital heart disease. If we look at the other causes of congenital heart disease, like in the right ventricular outflow tract obstruction, one cat eye syndrome, which is tetrasomic 22q, which is associated with tricuspid atresia, Wolff-Hirschhorn syndrome, Smith-Magenis syndrome, the 22q11.2 duplication syndrome. All these syndromes, basically, I'm trying to tell, my point is to tell you that we have, whenever there is a congenital heart anomaly, we have to start thinking in terms of whether it is chromosomal, it is a copy number variant, or it is a single gene disorder. Okay. Of course, one should not forget the environmental influences of congenital heart disease. So in medications, like for example, Epstein anomaly, it is known that lithium intake in pregnancy can cause Epstein anomaly. So the history for maternal intake of drugs is very important. Along with it, pre-existing maternal illness, in which pre-gestational diabetes, I think, is the most important contributor to congenital heart disease. And all these things are generally taken care of by the obstetrician by eliciting a good history. So if we want to approach a fetal cardiac anomaly, so it all starts with taking a proper history. So at least a three generation pedigree is a must to chart out all the family members and to find out history about presence of congenital heart disease or any other anomaly which might point out to some syndrome running in the family. History of infertility, miscarriages in the family. If there are, let's say, a lot of miscarriages happening, like the mother has miscarriages and then a child with a congenital heart anomaly, maybe there is a balanced translocation carrier which we are not picking up, which led to the miscarriages earlier, and now there is a presentation of a congenital heart disease. Detailed obstetric history, previous miscarriages, stillbirths, neonatal deaths, all these are very important history to elicit in order to come to a conclusion whether there is some kind of familial disorder that is running. Again, history of teratogenic exposure or presence of any chronic maternal illness such as diabetes or maternal PKU, and presence of any maternal infection. These things have to be asked. Once we are done with the history, obviously the first trimester screening, the NT-NB scan, increased nuchal translucency has a high, more than 3 mm, has a higher risk of, having a congenital heart anomaly. So whenever there is a history of an increased nuchal translucency, the straight away the thought should come that yes, I have to check the heart for a congenital heart anomaly. Along with it, presence of any NIPS test, which was done, which showed presence of aneuploidy. Level 2 ultrasound scan, of course, looks at growth. It looks at the other associated anomalies. It looks at soft markers. And after that, if there is presence of any major anomaly by which there is a suspicion of an underlying genetic disorder, a fetal 2D echo has to be performed. Now, previous genetic testing, if there is some variant which is already been identified in the family, some disorder which has been identified in the family and genetic test is available, it will make life easy for the geneticist, because now the geneticist doesn't have to run around and make perform extensive testing. We can just do the targeted testing for the disorder. And one should not forget to examine the fetus is affected, examine the mother and the father. The couple, one should examine the couple for clinical examination. So why am I saying incomplete penetrance? That means the father or the mother might be having the deletion of the 22q, but they might be absolutely normal. Okay. Unless we take an active effort, they might be having subtle dysmorphism or let's say a mild intellectual disability. the suspicion, the threshold of suspicion should be very low. That yes, we have to check for these disorders in the parents. For example, Holt-Oram syndrome, where the fetus may be presenting with a atrial septal defect, but the father or the mother has got only a triphalangeal thumb. Okay, so this is a case of variable expressivity, where the disorder is present in different levels of severity amongst in the same family. Okay, so just to make my point a little more strong, this is a case of the photo on the left side is a case of Digeorge syndrome, and we can see very clearly the tubular nose, the small mouth, which is a typical face of a Digeorge syndrome. And when we look at the mother, we will realize that even the mother had Digeorge syndrome. On the photo on the right, this is the case of Costello syndrome, in which it is known to have ventricular septal defect or a pulmonary valve stenosis. And we can see that the father and both of the children are affected with Costello syndrome, a typical coarse-looking faces with a down-slanted this. So once we have known the cause of the disorder, after doing a thorough clinical examination, we need to order appropriate genetic testing. So what kind of genetic tests can be offered? So starting from the simple karyotype, FISH, then a quantitative fluorescent PCR, non-invasive prenatal screening by cell-free fetal DNA, chromosomal microarray, next generation sequencing, or disorder-specific testing. So if we look at it one by one, karyotype is going to give you an overview of all the chromosomes. So it is best to do a karyotype in a case of an aneuploidy or a translocation. When you know the translocation, or when you know that this case is probably an aneuploidy, let's say trisomy 13, holoprosencephaly, and congenital heart anomaly, it is very clear that this case will be mostly Patau syndrome. So one can do either a karyotype or a FISH test. QFPCR will also give the same information. However, QFPCR is whereas karyotype and FISH is done on the cells. Okay. Non-invasive prenatal screening test actually is not to be advised for diagnosis, because first it's a screening test. Okay, it should only be offered if the patient or the family denies invasive testing. Otherwise, invasive testing is always the preferred choice of testing. Okay, chromosomal microarray is the test of choice in congenital heart anomalies, because it has been recommended by several of the societies, ACOG and ACMG, American College of Medical Genetics, that chromosomal microarray should be the first line tier test for either congenital heart anomaly or any major malformation detected during pregnancy. Okay, so chromosomal microarray is going to give information about aneuploidies. It is going to give information about copy number variants, which constitute around 20 to 25% of the congenital heart anomalies. So we are going to pick up most of the disorders by doing a chromosomal microarray. The challenge with the chromosomal microarray is basically the cost and the turnover time. It is going to take around 14 days, 2 weeks for the chromosomal microarray report to be available. So if the patient has come at the far end of somewhere around 23 weeks or something, so then these things become challenging to how to counsel the patient about the result might come after the cutoff of 24 weeks, and then they'll have to go through a bigger cycle of taking permission of fetal medicine board, etc. Okay, next generation sequencing. Next generation sequencing is now more and more being used at the prenatal setting. It was primarily used in the postnatal setting to evaluate for dysmorphic children, or children intellectual disability, or those who are having a suspicion of an underlying single gene disorder. But now more and more papers are being published where exome sequencing is being used in the prenatal setting. However, caution has to be exercised while doing exome sequencing, because exome sequencing looks at the single nucleotide variants across all the genes. Okay, so there is a high chance that it might report something which is of uncertain significance. So a lot of the times the exome report will give a report of variant of uncertain significance, and that creates a real problem during the prenatal period, because firstly the time is limited, and we need to give answer, and we should have actionable report. A variant of uncertain significance leads us nowhere. We cannot act upon the variant. We cannot give the counsel the patient about either to continue the pregnancy or to terminate the pregnancy. So we are stuck. So because these tests are sophisticated genetic tests, whenever such tests are being ordered, it is always better to consult a geneticist to be able to make the best interpretation out of the test. Disorder specific testing is done only when the disorder is known in the family. If we know that there is a particular gene defect which is leading to which has already caused a disorder in the previous pregnancy, we can just do the targeted testing in the current pregnancy and just give the answer to the parents that whether the variant has been transmitted or not transmitted. Okay. In the unfortunate event of, we can do the external examination, the internal examination of the heart, image the heart of the organs, as well as genetic testing on the tissue. So just to give you a flow chart, whenever we suspect a congenital heart disease, the first is to divide whether it's a syndromic heart disease or it's a non-syndromic heart disease. Syndromic heart disease, again, if the diagnosis is very clear that it's an aneuploidy, one can just do a karyotype or a fish and diagnose the aneuploidy, and after which the definitive management can be advised. If the karyotype of the fish is negative, or if one is not suspecting any particular syndrome, so one can straight away do a chromosomal microarray, as discussed earlier, which will give the deletion duplication syndromes. Now, in syndromic, let's say one has got a let us say it is atrioventricular septal defect, and along with that, the ultrasound is showing polydactyly. So straight away, the first thought is a Ellis-Van syndrome or a ciliopathy. So in that case, we know that the answer will be got by the single gene by a next generation sequencing. So in such cases, monogenic disorders, one can straight away do a whole exome sequencing to find out whether any single gene disorder is there. In cases of non-syndromic heart disease, one can again do a CMA as a first line investigation, followed by exome sequencing or rapid whole genome sequencing. That is only with consultation of a geneticist, because a lot of this exome will turn out to be negative also. So pre-test and post-test counseling is a must. Okay, because there are, as I have already discussed, that there are a lot of challenges associated with these prenatal testing, and most important is the limited phenotype. We are only getting information about the phenotype from what the ultrasonologist or the fetal echocardiography, the pediatric cardiologist, they have reported. We have not seen the baby as such. We have not examined the baby. So based on a limited phenotype, we are coming to a clinical diagnosis, and it is possible that the clinical diagnosis may be wrong. So again, to order genetic testing based on a limited clinical diagnosis creates its own set of challenges. The cost, the turnaround time, and the limitations of each test have to be discussed ideally, because each genetic test is costly and each genetic test is associated with the turnaround time. So for example, if we take karyotype, it will take at least 2 weeks for a karyotype to come. For a fish test or a QF-PCR, it is going to come early because these are rapid tests. Fish will come in probably 2 days, QF-PCR in 3 days. But if we go for microarray, again, microarray will take 2 to 3 weeks. And if one plans to do an exome sequencing, it will take almost 6 weeks. So just imagine if someone at 22 weeks comes to us And after that, we are ordering microarray followed by exome. It will be 30 weeks till the time, the diagnosis has been attained. So in such cases, one needs to club the test together, ask the lab to do expedited testing, probably at a premium cost. So these challenges have to be discussed with the patient, and they have to be discussed with a geneticist. Ambiguous results, variant of uncertain significance, I've already alluded to this concept. So a lot of these next generation sequencing tests will give up ambiguous results on which we have actually no actionability. So then we have to go is to do what is called as a trio exome sequencing. Trio means 3. So we test the father, the mother, and the fetus. When we test them together, the yield of the genetic test, the exome sequencing, increases by around 5 to 10%. And this is because we have already have the genetic information of both the parents, so that we can start filtering out variants which are present in the father or variants which are present in the mother, which otherwise we wouldn't have been able to conclude. A lot of the times carrier status of the parents can also be checked, and whether a child is homozygous or compound heterozygous for a particular disorder, that can also be checked by trioexome sequencing. So this, whenever there is a shortage of time, it is always better to do a trioexome sequencing. Problems of incomplete penetrance and variable expressivity. Unfortunately, genetics is complicated. So a lot of times it is possible that, for example, just for Dijot syndrome, I gave the example previously, that if either parent is the carrier of Dijot syndrome, it is not necessary that they will have all the features of Dijot syndrome. They might be completely asymptomatic. It is incomplete penetrance. But when they are planning a baby, there is a 50% risk of that deletion going to the fetus. And in that case, it becomes a big challenge for the family to be counseled about how will be the phenotype in the fetus. Maybe one fetus may present with a TOF. Other fetus might not have any other problem, but might present postnatally with intellectual disability. Okay, so these things come up during testing and the results, and such things have to be kept in mind while doing the counseling. And lastly, a negative result does not rule out a genetic disorder. Science is constantly evolving. So even if I get all my genetic test reports negative, there still remains a chance that this might be a genetic disorder, and it is probably not picked up in the today's era of technology. Probably it might get picked up after 5 years. So this caveat also has to be explained to the parents. Okay, because sometimes they feel negative test hai to sab theek hai. So that is not the case. Unfortunately, that is not the case. If it is, in fact, it is the other way around. If there is something that is picked up on exome, at least we can start counseling them. That see, this is the prognosis, and this is how we are going to manage. But if there is a negative result, then again we are little bit in no man's land. Okay, whether it is truly non-genetic or whether it was a genetic which was not picked up, these aspects have to be discussed in a nuanced manner. Okay, so once we have come to the diagnosis after ruling out, after doing appropriate genetic testing, now comes the prognosis. So obviously every parent wants to know what is of the fetus of a congenital heart anomaly. So obviously this all has already been discussed in the previous session, where whether isolated or syndromic. Obviously isolated have got better prognosis, syndromic have got a poorer prognosis. Presence of extracardiac manifestations, surgically correctable or not. Obviously Dr. Ashutosh sir has already alluded to this. And the financial and the logistical constraints. These also play a very crucial role in the overall prognosis. If let's say that a family is living in the villages, to expect the family to come to a tertiary care center in Mumbai or in a city, and to stay there for a prolonged period of time, to have prolonged NICU admission, and the cost associated with that, and the possibility of undergoing multiple surgeries, this is all going to create a lot of stress in the family. So these things also need to be considered, and these things will also impact the overall prognosis. Because if a family is not able to do that, obviously they are not able to give the optimal care to the unborn baby. So this is also going to affect the prognosis. Several factors affect the neurodevelopmental outcomes in children with CHD. A very important point to note that only genetic problems are not the only problems which might lead to adverse outcomes. Okay. This was also discussed in the previous session, that if there is prematurity, if there are perinatal complications during delivery, or if there is a prolonged NICU stay, or if there is a need for repeated surgeries, all these will affect neurodevelopmental outcomes in children. And studies have shown that almost 30 to 60% of the children postnatally have some form of motor delay, 20 to 30% about language delay, and behavioral problems and learning disability. So, to be able to give a holistic answer to the family is very important. We might just, say, ki, okay, theek hai, birth ke baad we'll do surgery and, the things will be okay. No, that is not how it is. Okay. Multidisciplinary care, that is why comes into the picture. It is very important to counsel the family that, look, there are going to be issues that might occur postnatally. Even if we do surgery, even the child might require prolonged NICU stay, child might have, we might expect some delay in the child, for which we can start early intervention by the help of physiotherapist, occupational therapist. So this anticipatory guidance is very important to counsel. So psychosocial aspects, a point which all doctors need to address, that diagnosis of a congenital heart disease in pregnancy is a very stressing problem for the entire family, and it is shown to have a significant impact on social relationships, financial burden, personal strain. And it has also been shown that doing a proper genetic counseling and receiving information on the why and how, it is shown to result in decreased level of guilt, depression, and anxiety. And this anticipatory guidance helps parents cope up with the upcoming challenges. So once we have, discussed about the cause, the prognosis, we have done the testing, we have found out a problem, then comes the recurrence risk. What is the recurrence risk? So again, as we discussed, that recurrence risk, most of the congenital heart anomalies are having a multifactorial inheritance. Okay, so the recurrence risk might be anywhere from 5% to 20%. That will come on the next slide. But in cases of Mendelian disorders, we can, if a genetic disorder is identified, we can give the recurrence risk. For autosomal dominant disorder, if it's a de novo mutation, that means the parents do not have the mutation and the parents are not affected, so the recurrence risk is very low. It might be just less than 1%. For autosomal recessive disorders, when parents are carriers for a particular autosomal recessive disorder, the recurrence risk is 25%. For X-linked also, the recurrence risk is 25%. Reduced penetrance, a variable expressivity, I've already mentioned about this. These create challenges in counseling. Amongst the non-Mendelian inheritance pattern, the multifactorial inheritance is the most common, 60 to 70%. And in that, the left ventricular outflow tract obstruction has got the highest recurrence rate. So the LVOTO group, which had aortic stenosis, coaptation, bicuspid aortic valve, and HLH. So these disorders tend to recur more in the population. So the recurrence risk is as high as 22%. Whereas if you compare in the non-LVOTO group, it is around 1 to 4%. So this is a table showing the recurrence risk for non-syndromic congenital heart disease. So if you just look at the AVSD, VSD group, so if the father is affected by the disorder, it is around around 1 to 5%. But if the mother is affected, there is a higher risk of the baby being affected. It is almost 3 to 4 times more. If one sibling is affected, the recurrence risk is around 3%. If two siblings affected, the recurrence risk goes up to 10%. For TOF, again, a little bit lesser recurrence risk, around 1.5% if the father is affected, around 2.5% if the mother is affected, around same if one sibling is affected, and around 8% if the if two siblings are affected. This I am talking about non-syndromic CHD. If it is a syndromic or if it is a monogenic, then the recurrence risk will be according to that, 50%, 25%. HLHS, as I mentioned earlier, it's got a higher recurrence risk, almost up to 22%. So once we have determined about recurrence risk in the future pregnancies, we should also have an idea about are others at risk. Okay, so this comes especially true for this long QT syndromes or arrhythmias, cardiomyopathies. If you have diagnosed a gene defect in a let's say long QT syndrome, obviously the reflex would be to test the parents, because parents both are adults, and if they are having long QT syndrome, then they are at risk of having a sudden cardiac death. Okay, but again, even for congenital heart anomalies, there is a cascade screening that is recommended. So if there is a long left ventricular outflow tract obstruction, since there is a high recurrence risk, it is recommended to at least do a baseline echocardiography of the first degree relatives. For the non-LVOTO lesions, if there is an established pattern of inheritance, if multiple members of the family are already shown to be affected, then probably we can get away by doing an echo once, or we might not do the echo. If there are multiple family members, yes, we can do an echo, otherwise not. Okay. And then last, we would, after looking at all these questions, we would now think about what is the best treatment available. So again, in pregnancy, there are only two options, either to continue the pregnancy or to terminate the pregnancy. Okay, if the malformation is very severe or if there is an established genetic cause, then the only option remains is termination. However, it is very important to do a non-directive counseling. Okay, because a lot of times families might be ready to accept a child with a genetic disorder because it's a precious pregnancy. They have tried for 10 years, 15 years with no avail, and the only child, let's say Down syndrome. I have had a case where after 10 years of marriage, the couple became pregnant, and then it turned out to be Down's antenatally. They decided to continue the pregnancy because so there is, unfortunately, such things do happen, but then parents do accept that. So in that case, we have to give them the option. Okay, now if you are ready to continue the pregnancy, then again, to give the anticipatory guidance about what to expect in the immediate postnatal period, what to expect at 1 year of age, what all surveillance is required, all these things come into picture. Okay. Postnatally, obviously, multidisciplinary team is must. It group of pediatric cardiac surgeon, neonatology, pediatric cardiology, all the doctors will sit together and create a plan for the baby. Okay. Is there scope for intrauterine therapy? I think now the world is moving at such a pace that intrauterine therapies are also becoming possible. So I'll just give 2-3 examples. Intrauterine in utero enzyme replacement therapy for infantile Pompe disease. So we all know infantile Pompe disease. It is a life-threatening disorder. It causes hypertrophic cardiomyopathy in infancy and leading to heart failure and respiratory failure. It's a very severe disorder. And studies have shown that if one starts the enzyme replacement therapy, that is the myozyme enzyme, early on, just after in the neonatal period, the outcomes are good. So one group decided to give intrauterine enzyme replacement therapy, and they have found to have good outcome. Just last year, this case made the headlines in news that a fetus underwent a rare heart surgery at AIMS. So this fetus had hypoplastic left heart syndrome. And the doctors at AIMS, they attempted aortic valve balloon dilatation, and because of which the hypoplastic left heart syndrome got alleviated, and their recent data shows that the baby is doing okay. The baby is already born and the baby is doing fine. So, I think the era where, hypoplastic left heart syndrome will be a poor prognostic marker will soon be gone in next 10-15 years if such kind of treatments are being available. Okay. So One more example is that of treatment of cardiac rhabdomyoma. So cardiac rhabdomyoma occurs in tuberous sclerosis. So in this case, the pregnant lady was given everolimus, which is a anti-mTOR inhibitor. So this mTOR inhibitor was shown to reduce the size of the cardiac rhabdomyoma. So, even in cardiac disorders, one can try in utero therapy, and these things will become more and more common as science progresses. And I cannot understate the the role of multidisciplinary care, which includes doctors from all the fields: obstetrician, fetal medicine, geneticist, pediatric cardiology, pediatric surgeon, neonatologist, pediatrician, occupational and physiotherapist. All of them together have to come together to give the best support to the child, because the unborn baby is at the center of all this, and it is our duty to ensure that the unborn baby gets the best care. So to conclude, the geneticist perspective is: first, diagnose, go to the root cause, then prognosticate, give the family best information about the outcomes, then counsel about recurrence risk, do cascade screening wherever applicable, and facilitate multidisciplinary care for optimal outcomes. So the take-home message is: congenital heart anomalies in pregnancies can have multitudes of causes. Search of etiology is very important. It helps establish the inheritance pattern, the recurrence risk, and the prognosis. Appropriate genetic testing and counseling enables families to make informed choices about pregnancy, and a multidisciplinary team approach vital for optimal outcomes. Thank you.
Thank you so much, Dr. Shan, for this wonderful overview of genetic association of cardiac anomalies. You have touched upon all the important points, and we know that genetics is very, very complex, but you have tried to simplify it for all of us. So thank you so much. So we know for sure that a team approach, as you have showed, is very, very important, of the obstetrician, fetal medicine consultant, the geneticist, the pediatric cardiosurgeon, cardiac cardiologist, everything have to sit together intimately once it is.
I think this forum is the perfect platform where all the specialists from all other fields are together. And the very fact that we are discussing these cases together highlights our commitment for multidisciplinary care.
Very true, very true. So thank you so much for your input, and I'm extremely thankful to you as well as Dr. Ashutosh for wonderful inputs about cardiac anomaly and its postnatal surgical outcome. And so all in all, I think we have tried to give important messages for antenatally diagnosed cardiac anomalies and how to counsel based on this multidisciplinary approach. So thank you so very much once again. And we are also thankful at the to conclude, I am thankful to my FOGSI office bearers, Dr. Jaideep Tan, President FOGSI, Dr. Madhuri Patel, Secretary General, and Dr. Girjawad, Vice President FOGSI, for always supporting all the academic activities of my Imaging Science Committee. We are also thankful to the President and Secretary of ISPAT, Dr. Saurabh Dani and Dr. Manjeet Mehta, for not conduct this webinar wonderfully, and of course Lilac Insight, who has supported all Hemant and Sutopa and everybody from Lilac team for giving the platform for this. Dr. Manjeet, are you there?
Well, thank you, Dr. Bela, myself, Dr. Niharika. Thank you so much for this wonderful opportunity. More importantly, thank you for such a wonderful webinar. So many doubts and such a big topic. Heart is always a complex issue. I guess for a fetal medicine, for an obstetrician, for a radiologist, heart is the most complex issue. और अगर देखा जाए मैडम, दिल की बात हमेशा complex ही होती है. तो वैसे मतलब बहुत वेल एक्सप्लेन एंड सच अ क्रिस्प एंड एक पूरा एक अम्ब्रेला की तरह हुआ. सो थैंक यू सो मच एंड थैंक यू फॉर द अपॉर्चुनिटी. Because of it, I was able to listen also. So thank you so much for this.
Part of it and helping so much in conducting.
Not at all. Yeah.
So,
Thank
Hemant?
you.
Yeah. Thank you, Hemant. Are you there, Hemant Sutopa? Yes, let's continue.
Hello, ma'am. Yeah, we are there. Thank you, ma'am.
Thank you, ma'am.
Okay, bye-bye.
Okay.
Bye, ma'am.
Bye, everyone.
Bye, everyone. You can stop the recording.
Okay, sir. Thank you. Thank you so much.